First, though, we will turn to our scheduled speakers. Dr. Jonathan Friedberg became chair of SWOG's Lymphoma Committee at last spring's group meeting, and he is with us 1 year later to provide us a best of SWOG update on the recent, current, and future work of that committee. Dr. Friedberg, thank you for joining us.
Thank you so much. It's really a pleasure to be here. As was mentioned, we did undergo a leadership transition. My predecessor had been in the position for 29 years, and that really gave us an opportunity to take a look at changing some of the way that the committee ran. New vice chair, Sony Smith from University of Chicago, translational medicine chair, Owen O'Connor from Columbia, and Mike LeBlanc, who's the group statistics chair, has stayed in the role of statistics chair of this committee. And I really am speaking on behalf of this entire leadership team. The lymphoma groups have struggled in the new era of the NCI steering committee, and that resulted in a strategic planning retreat that we had at NCI in the fall that was a clinical trials planning meeting that was organized by the 3 lymphoma group chairs, myself, my alliance co-chair, and the ECOG chair, as well as CTEP and representatives from the NCI. And this was a great day and a half discussion along with all the members of the steering committee to really determine what direction we are going to go in lymphoma. Some of the key takeaways from that, I think, are going to ring true to all of the diseases that people in this room take care of. It's obviously important to focus on important questions with major public health implications. Precision medicine seems to be a very important theme, and we're going to be moving in that direction, taking advantage of all support that's in place at NCI for these trials. Really try to make sure that there's a clear path to a randomized phase 3 or direct impact to patients when we create phase 2 trials. And particularly in lymphoma and other hematologic malignancies right now, we have to consider financial toxicity when the overall survival for many of these diseases is long and the cost of drugs is so high. We came up after that meeting with 3 key priority areas that we're going to be moving forward. A project in diffuse large B-cell lymphoma, a project in mantle cell lymphoma, and a project in follicular lymphoma. And by universal agreement, all of these projects are going to be intergroup projects, and SWOG is going to be taking the lead on the follicular lymphoma project with collaboration from the other 2 groups. So we'll just spend the rest of the time talking a little bit about follicular lymphoma as a paradigm for how we're thinking about lymphoma trial development moving forward. Follicular lymphoma is the most common of the indolent or slow-growing lymphomas. It has a variable clinical course. It's not curable with standard treatment, but it's highly treatable, and median survivals have improved. In the SWOG data sets and in others, the median survival of a patient with advanced stage follicular lymphoma may exceed 15 years. We know that this is a heterogeneous disease, however, and for example, clinical prognostic scoring systems like the one I show on this slide can differentiate that about a third of patients maybe only have a 10-year overall survival of 36% compared to a 71% 10-year overall survival if you have low-risk disease. And there has been less progress made in the area of trying to establish biomarkers for this disease and to understand this heterogeneity at a biologic level. Several years ago, gene expression profiling studies were able to show that a group called immune response 2, which was a signature that did not come from lymphoma cells, but came from the microenvironment, macrophages and dendritic cells, if those genes are overexpressed, the overall survival was quite low. But this has not made it into routine practice for a variety of reasons. These reasons include the heterogeneity of this tumor, not only between patients, but within a patient, the fact that most of these patients have a very favorable outcome, so you really need very long-term follow-up to make differentiation. And the fact that the signature that comes from the microenvironment may differ for other reasons, such as the treatments that the patients have had. And it's not clear whether the microenvironment signature is a surrogate for tumor biology or indeed a host response. and there's a great deal of debate in our field over which of those is the most important. Our history in follicular lymphoma has been deep, and the largest study in the modern era in follicular lymphoma is the SWOG-0016 trial, which started out as a 3-arm study but quickly moved to a randomized trial comparing R-CHOP to CHOP followed by iodine-131 tosatumumab. And the results of this trial were published a couple of years ago by Ali Press, and the details of the results are really not that important. Both arms did very well, and there was not any superiority of one arm over the other. I think one of the key messages, though, has been the excellent outcome in both groups, which is among the best outcome that has been seen in follicular lymphoma. And if you look at the overall survival curve on the right of this slide, you can see the challenge in trying to improve that. It's a good problem to have. But I think the other part is on the left side of the slide, there still is a group of patients that have an early fall off, and we're going to come back to the importance of that. In this study, we did some correlative science clinically to try to look to see if we could determine high-risk groups. And Ali did pick out a group of patients who had a very poor outcome by progression-free survival, but this was a very small percentage of patients, and therefore is unlikely to inform future trials. We also looked at vitamin D, and this is actually in this week's issue of Journal of Clinical Oncology. So if you haven't seen that, I'll just give you a couple of data points on that. There's a lot of reason to think that vitamin D may have an effect on lymphoma prognosis. It's been shown, in fact, to have such an effect in other subsets of lymphoma. We took the patients from the SWOG-0016 trial, as well as a couple of other legacy SWOG trials, and then used as a validation cohort patients from a French trial, the LYSA trial, that it was another large clinical trial in follicular lymphoma in the same era. We performed vitamin D measurements at baseline on patients who had samples from those trials, and these were all done at Mayo Clinic in a batched way, so there was no difference in laboratory techniques. Interestingly, and perhaps not surprisingly, there were a great deal of differences in the median vitamin D levels between these two cohorts. In Europe, the median vitamin D level was much lower. This may be due to dietary factors as well as some factors about epidemiology of the patients. However, the distribution of these is really the same. You can see the distribution curve looks similar. And we were able to show, for the first time in follicular lymphoma, that patients who were insufficient, described as two different thresholds based on the population with long follow-up, had inferior progression-free survival in both cohorts, as well as inferior overall survival. And the hazard ratios of the overall survival were impressive and actually higher than the other risk factors that we've used clinically historically in follicular lymphoma. Now, I don't think we're saying that we should run and treat every patient with follicular lymphoma with vitamin D, and we're not sure whether this is simply a surrogate for otherwise health of the patient, but there is reason to believe that vitamin D may impact certain therapies, like monoclonal antibody therapy, which is used ubiquitously in follicular lymphoma, and I think this does open the door to interesting future investigations. So I'll conclude by saying how we're moving forward. And an interesting observation from our 0016 trial is that as well as the patients did, 20% of those patients had disease progression within the first 2 years. And if you look at other trials in the modern era with similar regimens that have the same efficacy, even with rituximab maintenance, you can see that that same 20% figure within the first 2 years exists, and to me and to our group, that really defines potentially a unique biologic group of patients. These patients, when you look at them, then do very poorly. And the question is, and if you're not in that group, your overall survival is really outstanding. So if we could target that group in a precision way, I think that would provide impact for our patients. So how do we move to a precision approach in follicular lymphoma? I think that we've identified that early relapse after aggressive therapy represents the major unmet need in follicular lymphoma therapy. And this will give us an opportunity to define who this group is so that subsequently we can target this group up front in a precision way. Vitamin D deficiency is the first modifiable risk factor, and we're going to be looking at that as well. And our proposed trial design, which we're currently exploring, is to take patients who have early relapse after chemoimmunotherapy, get tissue from diagnosis as well as at relapse to inform the precision approach at diagnosis, and take those patients and randomize them to non-chemotherapy approaches. And we've had some very productive discussions, and we're hoping to be able to submit this concept to the steering committee this summer. I'd like to thank you again for this opportunity, and we'll keep you posted on how this progress proceeds.